Want me to say okay up here?
Sure, please.
Okay.
All right, Matt, you want to try the screen again?
Sure.
Or you got it? You got it. Looking good.
Looking good.
And you got your notes?
Got my notes. Ted is a good shucker and jiver. Shuck and jive. Shuck
Sugar,
and jive.
sugar.
Shuck and jive.
We have fun, don't we, man?
Oh,
We
good.
did.
Got to
And,
do
and
it.
and Ted, I'm going to throw out some fun statistics, and then we'll get rolling once Shannon turns it over to
Good.
us.
Hey, Shannon,
Yeah.
I have this uh, Zoom workplace outline around our screen here. Can I check X and get that out of here? Will that lose us, or can I get it away? Because it says get more done with AI companion. There's stuff
Oh,
around.
X that out.
Okay, and but I can keep the backing on the other stuff. Join the Zoom workplace. Okay, I'm good. I think
Okay.
as long as you can see me,
Yeah,
okay.
you're still live.
Okay, great.
All right. I'm going to admit folks in. I only got three. And again, when I planned, we had to switch this date for golf reasons. And, it was a holiday weekend, so we'll see.
Yeah,
We
Sorry
just,
about that, Ted. Half Moon Bay called.
piece of cake, man. I'm good with that. I love that course, but I've taken both
It's
actually.
great.
hey, Beth.
Hey, how are you?
Good. We're going to see you for Pride.
Um,
Are you,
Probably.
are you lovelies in town? I hope so.
I think we are. We have all these guests coming and oh my God, we just got back from a month in Europe and I'm in West Virginia now with my family, so I'm a little like, woo.
Okay. All right. So we'll
Uh,
let you
I haven't thought that far ahead yet.
well, we hope you had a great time in
Oh, we
Europe.
did. We
Oh,
had a
yay.
blast. Yeah, we got a really beautiful review for our film. I
Oh,
should send it to you all. Yeah,
yes, you
anyhow.
absolutely should. We want to celebrate your success.
Yeah.
Hello, Kent.
Hi there.
How are you?
Pretty good.
Good
How
to
are
see
you?
you. Yeah. How's the food service going? Have
I
you tried
think
it?
pretty good. The woman that they've sent to cook for us, Bella, is a lovely young woman from the university, but she's graduating and moving away, so we'll be getting somebody new.
Gotcha.
So yeah, or they come and they bring the groceries and they cook. They label everything, they print out instructions for reheating, and then they
Yeah,
clean up the kitchen.
I love it. So, Kent and his partner had said, "We're sick of shopping and cooking." I'm like, as you should be after
Right.
X number of
And we
years.
still end up going to the grocery store a lot,
Yeah.
but the whole idea of making meals was so unattractive to me, and it was really painful for Philip because of his back.
Yeah.
And so we also supplement it with a service from LA. Well, it's nationwide, but they make the food in LA called Cook Unity. And they're not frozen, they're just on
Yeah.
ice, and then they deliver to us on Sundays.
That's great. Excellent. Glad it's working out. So I suggested a service down in their area in Santa Barbara. So they're
Yeah,
testing.
it's all because of you,
Oh,
Shannon.
I
Thank
know you're
you.
you're well fed because of me.
And the two women that run it are like these amazing brainiac techie girls. I say girls, young, beautiful women that are just like, I don't know, the state of our country when you see young people so brilliant
Oh,
and articulate. I don't understand, but they're wonderful.
There's hope, Ken. There's hope.
yes, there's hope. Hi, Stephanie. Hi, Sharon. Hi,
Hello.
Ted. And hi to everyone who does not have their camera on. There's no, hi, Janice. There's no need to have your camera on, but we do love seeing your faces when we can. Um, so thanks for joining us today. My goodness, it's a Friday, almost the official kickoff of summer. For those of you who, I don't know, I grew up on the East Coast, so it was a much different sort of passage, rite of passage, let's say. Here, we're in California. It's like, wait, it's gorgeous all the time. What do you mean? But at any rate, happy long weekend to many of us. And we're here to talk about all things Medicare, Medicaid, health insurance. This hour is for you. Ted, do you know off the top of your head how many pages are in the Medicare and You US Gov booklet?
Well, I think the last I think I viewed that about 164 pages.
Yes. So,
I may be
wow.
off a couple, but I think I'm in
Yeah,
that.
it's definitely, and we have that as a resource for you. Please use it, take it. Perfect bedtime reading material. But we're here to distill those 160 plus pages into something that is meaningful to you. And so to do that today, we've got Ted Porter with us. Ted is an employer benefits specialist and senior planning advisor with more than 30 years of experience helping individuals and businesses navigate the murky waters of Medicare, employer benefits, retirement plans, and insurance strategies. We love Ted for his enthusiasm, his approachable style, and his commitment to education and community. He is a Bay Area native, avid golfer, a musician, as well as wonderful, wonderful other things. And for those who don't yet know Matt, let's fix that. He's our Chief Partnership Officer here, as well as a Senior Wealth Advisor. Matt loves connecting with professionals in areas that complement Brio's range of services. He's also a golfer, so maybe there's a tea time on the horizon for you gentlemen. And he's also deeply committed to giving back and even more deeply committed to his two pups. So,
Shannon,
with
real quick,
There
oh,
it
there,
is.
Stephanie's got it live.
yes,
Okay.
127 pages.
127. Oh, they condensed
127.
it more, Stephanie.
Pardon?
Yeah.
They condensed it more. That's good.
Oh gosh, did they cut benefits?
Oh
They didn't get
no.
any benefits.
No, we're safe
Uh, and we,
there.
and we'll have that as a PDF resource to share with you digitally after the session. So with that, let's dive in. Matt's going to kind of set the stage, but again, this hour is for you. So if you have specific questions, uh, clarifications, just shout them out,
Yep, shout
either
them
live or
out.
in the chat.
Yep, put them in the chat over there. Thank you, Shannon, and thank you, Ted, and thank you everyone for joining us. Happy Friday. Happy early Memorial Day weekend. All right, so the book is one thing, but distilling it down to 24 pages is a work of art. And Shannon, thank you for helping us distill this down. Appreciate that. So you guys, I want to start with some fun statistics before we get into the slides. 70 million Americans are enrolled. 70 million. Every year, the federal government spends $1.1 trillion on Medicare. That maps out to about $17,800 per enrollee or $3,000 per American. This is 13% of the overall federal budget, so it is enormous. And I think most of us know that either we pay in through over the years or you qualify, you're 65 and older. So Ted and I are going to get into the core components of Medicare, and we were mindful about the demographic on this session today, meaning we've got some people that are already in Medicare and know it inside and out. Then we have some other people that haven't entered Medicare yet. So we wanted to keep this relatively broad, but deep enough where you kind of walk away going, oh, wow, I've got some serious homework to do. But there are some very good resources to help you as well. So part of our hosting these sessions is academic in nature, education, education, education. The more we can learn about very complex, large subjects like this, the better. So Shannon said, type in a question. If we don't get to it or we don't know the answer, we promise to get back to you. Ted is about one of the best Medicare specialists I've worked with over the years. And again, 30 years of that. Ted is also living and breathing Medicare as we speak, so he knows it inside and out, and he's going to have some great examples. All right, what other fun stats can I get? And then we'll jump in. 90% of the enrollees qualify because they're of age 65. 9 to 10% qualify due to significant disabilities. So it's a big range. There are two gigantic trust funds that fund Medicare, and they're both through the federal government, U.S. Treasury, as a matter of fact. We might tie in that a little bit here, but let's dig in. Let me share my screen. And Shannon, can you see my screen
I
yet?
can see your yeah, well, I could.
I had it. I had it. Let me go back. All right, now we go. There we go. All right, can you see that okay?
Yep. Mm-hmm.
All right, great. All right, let me get up here. All right. So how to qualify? There are numerous ways to qualify, and thank you for those of you who have been paying in over the years, 40 quarters, or have a spouse who has been paying in also, age 65 or older. Qualify for Social Security disability, that's the 10% we just referenced. End-stage renal disease, that's kidney failure, kidney disease, and ALS is Lou Gehrig's. Those are immediate entrance into the realm of Medicare. Those are special exemptions. And then we'll talk a little bit about large network. Large network means there are certain groups of doctors and medical professionals that will be accessible to the larger population versus the others, depending on what you are enrolled in. Part A, Part B, Part D, Part C. There's a lot of parts to Medicare, some of which have been phased out over the years, and Ted might jump on some of those as well. But Ted, anything on this you want to add before we move forward?
No, I think that's pretty straightforward. On the network, it's a lot different. A lot of times people think that I've been on a group plan and I've been with Anthem or Blue Shield or United Healthcare, and they have an in-network program, and I have to stay within that network. With Medicare is a federal program, it's a national program. So if you have, as an example, a Medigap or a Medicare supplement plan, you can go to any contracted Medicare provider or facility anywhere in the country. Doesn't have to be just in California. So it's very large network. You just want to make sure that anyone you're going to see is a contracted provider. So I think that was what I would add to that one, Matt.
Perfect. Love it. Love it. All right, Ted, let's share.
Can
Yeah,
I ask a question?
Yes.
This is Eugene. Is this you have to satisfy all these criteria or just some of them? Like, do you have to have paid Medicare taxes for 40 quarters and be 65 and qualify for SSDI and like it's clearly not and, right?
No,
So
no. These are just different ways in which people qualify for them. The disability benefits, you have to be on Social Security disability benefits for 24 months. On the 25th month, you automatically become eligible for Medicare A and B, and they send you that card. It's up to you if you want to keep it.
and
But no, these are not and. That's a great question, Eugene.
so the only end is 40 quarters and 65 years or older, right? Without any other conditions.
Yeah, well, once again, if you are, let's say I have a lot of clients that are under age 65 and they've
Uh-huh.
had a chronic illness and they've been on the Social Security disability benefits, and on the 25th month, let's say the person's 55 years of age, they're eligible for Medicare A and B, and they can get an advantage plan or a supplement plan at that time. So it just depends upon the situation.
I see. And with respect to the large network, what fraction of US doctors would you say is in this network?
Oh, that's a great question.
90% or more.
Wow.
Gotcha.
Yeah.
Okay.
It's
good.
larger than most people would think, right, Ted?
Yeah. Yeah. And you have to clarify between the Advantage arena, the Medicare Advantage Part C, and the Medigap, Medicare Supplement protection. So if you want complete freedom to see any contracted Medicare provider anywhere in the country, you don't want Advantage coverage, folks. That's Medicare's version of an HMO, and you have to stay within a guideline of providers and get qualified referrals and things along that line. If you like the freedom of choice, the Medigap plans are the way to go.
And there's tons of those.
Yeah.
Question on back to that other slide about the kidney renal disease. Is there any age, end stage renal? Are those people on SSDI originally, or is that just a whole separate category? It could be any age.
Well, unfortunately, it can be any age. You don't have to be 65 or older. We've had younger folks who've just had genetic problems in this particular area, so they qualify for these things before Medicare. So it depends upon your health, depends upon, how you're working within the Medicaid or Medi-Cal system or Medicare system in order to qualify for that. So there
Okay,
isn't any particular.
Okay, my question was, you don't have SSDI under it, so I'm wondering if they get on it without having Social Security disability insurance, or do they have it?
They typically would have it because
Okay,
they
got it.
qualify.
Thank you.
Yeah.
Thank you.
They're officially registered, so to speak.
Okay, got it.
Yes.
Okay. All right, you guys, we have great questions so far. We're going to, if we don't get through all the slides, we apologize up front because we'd rather have the questions coming. But like I said, we've got about 20, 23 slides. We can move through these pretty quickly, but keep the questions coming. Before we get into parts A, B, C, and D, Ted and I and Shannon want to kind of just do a quick high level overview of what's new in 26. Because with a lot of government programs, things are constantly changing. They're tweaking them. They're adding new things and deleting new things. So one of the biggies here is capping of what you pay for prescription drugs on Part D. And I don't know how many knew this, but $2,100 in 2026 is now capped. And so once you reach the cap, the co-payments for covered Part D technically go away. Pretty big deal for that. And Ted, any history on that you want to share with maybe kind of what you've seen over the years?
Yeah, that's a biggie, Matt. For example, folks, in 2024, the out-of-pocket gap, or by the time you reached $8,000 out of your pocket, you reached what they call the catastrophic level. And that was in 24. In 25, Congress found a way to fund that 8,000 down to 2,000. And in 2026, it went up to 2,100. So we have a lot of clients that have Parkinson's medications, cancer medications, things that are not generically dispensed. And those out-of-pocket limits coming from $8,000 down to $2,000 and 2,100 was a massive
Huge.
funding project, which I thought Medicare did a terrific job with doing that. And that is also, we'll talk about the IRMA stuff coming up, but that's all a part of keeping this massive program afloat and financially secure for the future.
Great, thank you. The only other one on here, I mean, they're all important. It goes without being said, early detection matters. I think most employer plans, even the federal government, even here at Brio, always want people to be doing things that can be proactive to help their health, so to speak. So the early detection, they're starting to add more things like colorectal cancer screenings. And bear with me, this is a new one, included tomography, colonography. Who wants to say that 10 times fast? Getting screened is an important part of cancer prevention and early detection. So we always are advocating you guys go see the doctor, get checked up, do the physicals, all those things. Because we're all paying into the system still, but the more healthy we can try and get to a point where we're preventing things, the better. All right, let's dig in. So Part A, we're going to start with Part A, what it covers, and we're going to talk about what it doesn't cover. So a lot of these are broad, and I would say the home healthcare and hospice one are very important. Skilled nursing facility are important here. Inpatient hospital care. So if you think about this being the original part of the Medicare program, these are kind of the fundamental foundational pieces that we're getting assistance being paid for that we've been paying into over all the years. Ted, on here, any of these that are more important than the others that people should consider?
I think they're all very important, Matt. That's a great question. Obviously, California hospitals are 6 to 12,000 bucks a day. So Part A handles the inpatient hospitalization. If it's bare bones, you've got some deductibles and things like that, but it's terrific coverage. Skilled nursing facility, they don't do a good job there. They've never claimed to. You get 100 days of skilled nursing facility if you're hospitalized for 3 days and you're placed into a skilled facility within 30 days of discharge. Medicare covers the first 20 days in full. And then from the 21st through the 100th day, you have your supplement or your advantage plan. They pick up the costs that Medicare doesn't. But the key is that you have to have skilled daily care Monday through Sunday, rehabilitative care in order to still qualify for any nursing facility care under Medicare. So I think the average stay after a hospitalization is about 5 days nationally because people get better and they don't need that skilled care. They may need some intermittent care or custodial care. So that's an area that is very big as far as the financial exposure to that.
I'm gonna repeat what you said. $12,000 per day to sit in a hospital without coverage, correct?
Correct.
Okay, let's talk about costs because everyone's kind of thinking, where are the costs here? All right, so Medicare kind of breaks it down into several increments by tranches of time, if you would. So the first 1 to 60 days after the 1,736 deductibles met starts kicking in. Then you go day 61 to 90, 434 copay. It gets more expensive as you go along. So past the day 91, it gets really astronomical. And this is where we do a lot of coaching on long-term care planning and long-term care budgeting, long-term care financing. Because if you happen to be, unfortunately, in the hospital past that day 150, it gets scary, right, Ted?
It does. Yeah. And you think about it, folks, from day 1 to day 60, after if all you have is bare bones Medicare and you don't have a supplement or an advantage plan, $1,736 in 2026 is a deductible that buys you 60 days in a California hospital. That's really good coverage. Medicare Part A and Medicare Part B, which we'll get into, are the federal program. They're the main risk takers. So they're the ones that are determining your eligibility for hospitalization or outpatient surgeries, and they have these deductibles and co-payments in place for that reason. So
yeah, and you start scratching your head after a while. It's like, I don't know how people afford this in general. But again, with good proper planning, there are numbers of strategies that we try to employ and help clients with to offset that unexpected blow when it happens. And it does happen. All right. Let's move into the next big piece here, Medicare Part B, what it covers, preventative, emergency room. Ted, I may want you to comment on durable medical equipment. Clinical research is another one that's big, and then mental health care. That's a really big one that's come into its own in the last several years. I myself have a couple of family members that are dealing with mental health. They're in their 80s and 90s, and it's brutal. It's brutal to watch, but knowing that there is a cost-effective way of getting treatment helps take some of that numbing sensation off the table. But Ted, anything on here? How extensive is the emergency room visits and urgent care? Is that really good if someone needs an ambulance to pick them up and take them to the emergency room?
well, the problem is when people want to use the ambulance as a taxi, that doesn't work very well. But when people actually have had, God forbid, a heart attack or a stroke and in their home and they get the care and they have an ambulance to the hospital, Medicare Part B does a terrific job with that. They really do. And, each situation is a little bit different, but from our experience, when somebody has A and B and they've got a good supplement or a good advantage plan over the top of this and they have a legitimate claim, Medicare beautifully pays for these things. On the preventative care services, if you have a pre-existing condition and you're approved for Medicare, which you are when you're new to Medicare, we don't even answer health questions on the application. They will always honor when a doctor prescribes preventative care benefits. We want to do the annual screening exam, or if you had colon cancer or breast cancer. But when you're new to Medicare, Medicare offers a couple of well care type benefits where they get a baseline that you work with your doctor, you're under a new program now. And so the preventative services aren't typically what you find yet if you have a group insurance plan. They're more comprehensive, but they're a baseline on the preventative side. And if once again you have a pre-existing condition and you have to have these annual exams, that's a whole different coding than just coming in and getting a baseline on your health. But they've moved along. We didn't used to have this at all. They've really been trying to fund more preventative care services. Mental health is there, inpatient, outpatient, limited outpatient prescription drugs. Once again, it depends upon the situation. You need to have a Part D plan in place, folks, either through your Advantage or your supplement plan. But there are times where an outpatient procedure like a knee replacement or a knee surgery of some type, they will have outpatient prescription drugs that they can give you through Medicare without you having to go to a retail drugstore to get them.
Great comments. And we'll get into Part D in just a second. But let's touch on the deductible over here, 283. Does that change from time to time, Ted?
Yeah, it's an annual moving target. I think last year was 257. This year is 283. I think we had 1 year during COVID, Matt, where the deductible did not change. The co-payments didn't change. There wasn't any increases in the IRMA charges. So, but it's a moving target to keep this funding mechanism moving along here. And so the deductible is a moving target. Medicare pays 80% of their approved costs. That's an interesting program. That if you have only bare bones Medicare, you're exposing yourself to what they call excess charges, which they don't cover any of that. If you have a supplement or you have an Advantage plan, then you have protection on those excess charges. So you want to be paying attention to that.
Yeah, and we'll get into the Advantage piece here, but let's talk a little bit about premiums next. We'll just do a quick comparison on Part B and Part D, and we
I
are
have a
going to get into
question.
Part. Yes, go ahead, Kent.
If you sign up for Medicare, which I haven't yet, are you automatically in Part A and Part B?
You have to sign up for both, Kent.
Okay. And the
Automatically.
reason they're divided in Part A and Part B is because there are different deductibles and payment schemes. Is that why?
No, they're different levels of coverage. So Part A
Okay.
is inpatient, Part B is outpatient.
Okay.
So anything that's billed other than through the hospital, Kent, is billed through Medicare Part B as in boy.
Okay.
And just as, and this is probably more than you want to know, but the funding behind both A and B are different also. Part A is technically funded by taxes, revenue, things like that, whereas Part B, the federal government can employ a cost of living adjustment, which is, to Ted's point earlier, is like, okay, there's more variables that can be controlled with Part B funding, whereas Part A, there's speculation, just like Social Security. Could that run out at some point because the expenditures are much higher than the intakes coming in from revenue and taxes? So there's a good comment, but that was a good question. Okay. Premiums, Part B and Part D. And for those who don't know, Part D is all about drugs. So if you think about D, big capital D for drugs. But how do you pay for these premiums? And I think the important part on this slide is, as an individual in 2024, and these are a little dated, so these numbers have gone up. We do have current data for 2026 and 2027, but part of the reason we're putting this on here is because of the IRMA 2-year look back period in
And
terms of qualifying. Yeah, go ahead.
if you could, edify those who don't know what IRMA means.
It's an income-related Medicare surcharge based upon your income. And everyone that's in Medicare is paying some level of IRMA charges, and it's related to the funding of Medicare. The more you make, the more you pay. And in some cases, if you're in a Medicaid or Medi-Cal type level of income, it's all means tested. The average IRMA charge can be eliminated or compensated for, but for most cases, whatever the current rate is what you're paying, along with a Part D surcharge as well. Those are the two. B as in boy, D as in door have the income related surcharges. And that's kind of how this thing is working. It's been going on now for a number of years to try to help fund and keep this Medicare program afloat.
And here I thought it was just some grandma.
Irma,
It's more
Irma,
grandma, Shannon.
Irma. It's such a strange acronym, but it's so critically important. And when we do a lot of tax planning, our advisors are always worried and thinking about IRMA and how it impacts our investors because that could bump them accidentally or purposely into a different tax bracket. So IRMA is critically important for both cash flow, tax planning, and everything else that goes into it. But the main message on here, you guys, is if you look over here on the right-hand side, the comparison here as you go up in income, so income's going up down here to where you get to 500,000, 750,000, are commensurate with the premiums that have to be paid. So 202.90 going all the way up to $689.90 with the more money you earn in terms of income that qualifies for the IRMA requirements. Ted, anything else you want to add on here? And a great resource here is the costs on Medicare.gov. We have a lot of people that do spend a lot of time on Medicare.gov. That is the primary resource. But when you look up cost, there's a lot of really good breakdowns of how much all components of Medicare cost.
Yeah, I think that the key on this that people maybe not be aware of is that let's say you've been a high wage earner for the last, 20 years of your life. The IRMA charges are not looked at how much money you have in your 401ks or bank accounts or IRAs. What they're looking at is your income. And so if people sold a home 2 years ago or had a big sale or something, and now they're retiring and their income is moving from one all the way down to a lower area, they can appeal. There's a form on the SSA.gov website. By the way, SSA, Social Security Administration, is where you sign up for Medicare A and B. You're not initiating your income benefits, but there's a tab there for federal Medicare. So, you can develop all that and look at that situation from there. So,
And we'll get into all the enrollment options, lots of enrollment options, not just one way to enroll.
yeah.
Yeah, go ahead, Ted.
And you can appeal that there's that form that you can, it's a change of life form, something along that line that will allow you to appeal if you're in the higher bracket 2 years ago. Now you're not going to be, and they are making changes for people. So I would not hesitate to do that if that comes up for you.
So Ted, if I want to go and get a facelift, does that count?
Well, let me tell you this, Matt, and I'm not laughing at this, but we've had severe car accidents, burnings, things that have occurred that are not just preventative or you want to make yourself, look like you're ready for Hollywood.
They're not elective.
That's right. That's right. They do a great job in reconstruction surgery and things along that line, but no, they're not going to cover an eye lift if you want to have one of them.
And I know we were talking about this before. Massage therapy, there's kind of a stereotype of, oh my God, I'm going to pay $150 for a massage. Can I write that off through Medicare? The answer is no. However, if you are medically in need and the doctor has given you a prescription to have massage therapy that is impactful to your recovery, then there could be an exception to that. Is that right?
Absolutely. Yeah, that's all depends upon the situation. If it's just because you've had a tough week, and I need a massage. That's different than if you've had a back injury, and along with
Yeah.
physical therapy, they're recommending you have massage therapy to help to go along with that. That's a whole different category.
So, message here, everyone, is with both Parts A and Part B, definitely become familiar with what's covered, what's not covered. We oftentimes will lean the TEDs of the world. And by the way, Stephanie, who is on the call here too, can be very, very helpful also.
Wonderful resource.
She's part of our partnership network as well. So thank you, Stephanie, for joining us. All right, let's jump into the biggie. Part D, drug prescription. And I don't know about you, but I've got several friends and family members that are on very specific medications, ranging in cost, if they did not have coverage, from $100 a month all the way up to $88,000 a month. Medication is extremely expensive. So to be able to have this type of coverage is probably one of the largest benefits for being able to have Medicare at our disposal. There's the IRMA piece there, so applies to Part D coverage. And then I think the important part here is the reality that everybody has a very different medical situation, and everybody has different drug needs at some point in their life, God forbid, but a majority of mature Americans in this country have and are on some type of medication. It's just the way it is. If you're not, good for you, and you've got good genes and you've got good health, but I'd say the majority of people are going to take some type of medication at some point. Ted, out-of-pocket costs on this, $2,100, no additional cost for covered medications. Give us some wisdom on drugs, if you would.
Well, prior to 2006, we didn't have prescription drug coverage through Medicare, by the way. It was the Bush administration that passed that $30 trillion deal back then. And when we first started, we had that big donut hole where nothing was covered once you reached a certain out-of-pocket threshold. Over the years, that donut hole has become a coverage gap, and little by little, as funding is able to do this, you want to get to the point that there isn't any gap and you're covered all the way through. So the prescription drug program has been an evolving situation based upon funding. And with the new addition of the $2,100, I mean, very expensive medications. And I have a client that's in San Francisco, and he's required to have this medication for one of his kidneys, or there's something there. And that is just like Matt had explained. It's an $88,000 program that he has to be on. And he was coming off a group plan onto an individual plan, and we were able to get him the coverage. And his medications that are extremely expensive, and he needs it to be able to stay alive, are limited this year to $2,100 out of pocket. It's a huge, wonderful benefit to have. And I think people are very happy with it. And now as we move towards lowering the cost of the medications behind the scenes, hopefully a lot of these gaps will be even more filled up, if you will, and financially more stable for people. But this is a biggie, and if you're, a lot of times people will be wondering about cancer medications. If you're receiving cancer through injections or through going to a facility, those are not Part D claims. That's not a retail prescription drug purchase. Those are through Medicare Part B as in boy. And so those are fully covered under the Medicare Part B along with supplement or advantage plan. So any retail facility that is contracted with Medicare is where you want to be. And
all right, so you just hit it on the head. Part C. So we've covered A, we've covered B. We're going to move into Part C now. Covers a lot, but doesn't.
Wait, can I just ask a question about
Yes.
If I'm on a Medicare Advantage plan, do I also need to be on on Part D?
No,
Or
it's a great question, Suzanne. Your Medicare Advantage plan
yeah.
should offer a Part D prescription drug coverage plan within it.
Okay, I believe it does, but I just got confused by.
Yeah, no, that's a great question. Yeah.
Yeah.
There are some that don't because maybe somebody has veterans uh, RX coverage through their service, but most of the time you're going to find Advantage plans, whether they're Kaiser, United Healthcare, Humana, have prescription drugs tucked within that benefit. And that's because they're subsidized by Congress.
Mhm.
The Advantage plans were developed in I think the late 60s, early 70s. And they basically were a way that which you could kind of lower the cost. You're literally assigning your Medicare A and B benefits over to the carrier. The carrier is receiving a compensation every month from Congress that's been set up behind the scenes. That you're not a part of that. And so Advantage plans, they're modified in terms of who you can see, and but if there's enough money in the plan, they might be able to offer some podiatry or some limited vision or dental or something like that. But they're very compact. You have to stay within the network. You have to get authorizations. And but for those that work well, it's, Kaiser members love it. They move from Kaiser onto a Kaiser Senior Advantage plan. Their medical numbers don't change. Their physicians don't change. They're just under the new umbrella, federal Medicare, as a Medicare Advantage recipient.
So Ted, do
Okay.
do a lot of people want or get Medicare supplement?
Well, once again, which I love about Brio, because you're an educational as well as one of the best advisory firms I've ever had the pleasure of working with, but you educate people. So I have found that the average person that doesn't get the education looks at the cost. Well, what's this going to cost me? And they look at an Advantage plan, and maybe that's subsidized that year at zero premium, or maybe it's 25, 30, $40, and they have a pre-existing condition. They get on the plan, and a year later something else happens and they're not getting access to the doctors they want, and now they want to get out of the Advantage plan and get into a supplement plan, but they've passed the guaranteed issue window and they can't qualify now for supplement coverage. So you really have to know the difference between supplement and Advantage, and that if you're an Advantage member and you want to move to a supplement, you have to be very healthy to qualify for that. You can only do it during certain times of the year. We'll talk about that, I think, coming up. So you want to be careful. If you like freedom of choice, folks, Advantage plans are not the place to be.
All right,
Without,
let's show it in motion, Ted. So this is titled Slip and Fall. God forbid any of us slip and
I
fall.
was going to say that should be titled Shannon.
Shannon slipped and fell this week earlier. Are you okay, by the way?
I'm doing okay.
oh, I didn't know that, Jan.
It's all right. Just
So you slipped and fell, and Ted, you've had recent knee surgery. So can we use you as a guinea pig for this, please?
Absolutely.
So
Absolutely.
Ted has an affinity for golf, and Ted and I were talking about this, and Ted believes that he might have twisted and torn some ligaments in his knee from golfing. All right, happens with age, happens with frequency of playing a sport, whatever. You could walk down a set of stairs and do something. So, in order of the sequence, Ted, we've got traditional Medicare, parts A and B on the left. Then we move into Advantage Part C, deductible costs, and then we go to supplement. In your specific case with your knee injury, have you had to do the supplement or no, not yet?
No, I have Medicare A and B, and I have supplement plan G. I could have F. I'm 73. I could have plan F. We can get into that another time. But G is the supplement plan that I have in place. And as an example, when I went to my referral doctor, orthopedic surgeon, Dr. Bell, the first thing that they asked me, what kind of insurance do I have? Well, I have a Medicare A and B, and I have a supplement plan G. And they said, perfect, we're good. And I haven't paid a dime out of my pocket for the procedure or the PT. And I've had several of those sessions. So the supplement plan allowed me to get right in there. An Advantage plan, you want to make sure that Dr. Bell, as an example, and the Hacienda Surgical Center are under that Advantage carriers network that you want to see. And if they're not, then those are out of pocket exposures that open up more costs out of your pocket. So that is a real key difference, Matt, between what you find in supplement coverage for the freedom to move around that you want. Those are contracted facilities. He's a contracted Medicare doctor. That's want to be sure.
Yeah. So Ted, if you don't ask, you may stumble into a beehive.
That's correct. Yeah, you want to always know, especially in Advantage plans. Kaiser is set. You're only going to go to staff model doctors there. They're all employees of Kaiser. But if you have United Healthcare, you want to make sure you understand who the network is and who's available to you, so you're not stuck in a financial position you weren't accounting.
And is there any centralized resource for that, or do you have to ask each individual provider?
I ask each individual provider, Shannon. I go to the doctor, the specialists, and I get with the people that are doing the billing and because they're the ones that are the point of service that you can trust. That no, we're not. Yes, we are. Oh, yeah, it works well. You know what I mean?
As a point, and I know people will see this, but you mentioned Plan G in the Medicare book. On page 76, you can see all the Medigap plans and what they cover.
Yes.
And this is super important to your point of understanding the value. It's honestly, it's not so complicated once you look at the chart. What I have found with people that have maybe a little bit more wealth or are using financial advisors, they value that expertise. They want to be able to curate their care. And when you have a Medigap plan versus Advantage, you could go to Stanford if you want. You could go to Mayo Clinic if you want. If you have Kaiser or United Healthcare, that's not going to happen.
Yeah,
so you just, I mean, it's that whole value added.
Absolutely.
But I think it's important to understand there's more than G. You can look at it. There's some that have international coverage, some that don't. And to what you said, and I think I have this correct, but I'm not sure, that you're better to start with a Medigap because you can always lower your coverage and you don't have to medically qualify. Whereas if you start at an Advantage, which is a lower, broader concept, to go get better coverage, you have to medically qualify, which is a lot harder as you age. Is that correct?
That's absolutely correct, Stephanie.
Higher and drop it.
Yeah, and unfortunately, a lot of people don't know that.
Right.
And
I was going to put a plug in for both of you. So to piggyback on Shannon's comment about a centralized resource, when we get into the depths of coaching on Medicare, we will often turn a client on to a Ted or a Stephanie to
nice to meet you, Stephanie.
Well, to be the consultant. But what's beautiful about this, everyone, is Ted and Stephanie, correct me if I'm wrong, you guys get paid by the carriers. Our clients don't pay you for your advice, but if you vector them into a particular type of plan as a fiduciary, you get paid by the carrier. So technically, our clients are getting free advice from people like you and Stephanie. Is that correct?
Yeah. And something that I think is, and Ted, because this is like so important, and it's really hard for people to grasp, is that these federal plans in the Medigap, like Plan A, B, C, D, E, F, G, all of those, that coverage is the same no matter what carrier you get it from because it's federally set up. And so you could call 5 different people based on your age, 5 different carriers, and based on your age, you're going to get the same coverage. You might get a different price, correct?
Yes, these are standardized national
Yeah.
plans, whether we're talking in California or Florida. Plan G is Plan G, Plan N is Plan N. No
Exactly.
insurance carrier can manipulate any of the benefits. Each state has its own insurance program, and the plans may be called differently under different carriers. But Stephanie, you are absolutely correct. They're the same coverage no matter where we go.
Yeah.
Great point.
I'm so glad this conversation just went in this direction because I feel this is Suzanne and I have a question in the chat, but
Yes.
now I feel like it's being addressed in some way because this is what I was hoping to get some clarity about whether or not I should stay with this Medicare Advantage plan, which I do like. It's SCAN and I like it. I just started with it this as of this year. But I'm thinking because I have this international situation, I'm wondering if I would be better off with a Medigap plan.
You know, Suzanne, I have never advised just using Medicare with a supplement G or F, whatever, for international travel. If you're going
It's
to,
not international
Yeah,
travel because I live here. I mean, I live here, but I go back once a year for a month, go
that,
back to the US. So that's
yes,
when I do all my doctor visits. Okay.
okay, all right. So you live outside of the United States, but you come back to the U.S.
Yeah, exactly.
In
Yeah.
Morocco, Ted.
In Morocco. Well, that's beautiful.
Yeah.
So how's it been working for you so far?
Well, it's actually been quite wonderful, and I've had a couple of medical emergencies, and actually that's one of the reasons why I went with this Medical Advantage Plan SCAN because they cover international medical emergency.
Yes.
And so, that was one of the reasons why I went with them. But I don't know. Now I'm kind of confused as to whether or not I should.
Suzanne,
Yeah.
out of the 10 Medigap,
Yeah.
there's 1, 2, 3, 4, 5. There's 6 that cover international emergency. So,
Right.
SCAN covers it, and 6 out of these 10 cover it at 80%. I think since you come to the States, maybe the question you should be asking yourself is, what kind of flexibility do you want with care? Because SCAN
Right.
obviously won't have the flexibility that you would have with a Medigap plan. Rather than
Right.
the international, you have international for emergency. You could get Medigap with emergency. So that kind of takes that out of the mix. It's like,
Right.
what kind of flexibility do you want when you're in the States for your care? Ted, does that sound reasonable?
And how long, Suzanne, have you been on Medicare?
I've been on Medicare since I was 65. I'm 71. I've been on Medicare since I was 65, and I just started with SCAN as of 2025. I just switched over. This is the first year I'm in the midst of it.
Okay.
But my question, because did I understand correctly that you're saying that because I didn't choose Medigap to begin with, that it might be difficult for me to switch over to Medigap at this point?
Yeah. Yes.
Exactly.
What I recommend in all cases,
Yeah.
that if you're planning from moving, whether you're living here in the States or in your situation, coming back to the States, if you're considering moving from an Advantage plan, which you can only do between January 1st and the March 31st of any year anyway, you can't do it whenever you want unless you have a qualifying special situation.
That's okay
Well,
because I'm due to do that this upcoming January anyway.
you
Okay.
want to get pre-qualified. You want to get an application from Anthem or Blue Shield or whoever. You want to be able to go down those health questions. And if you can
Okay.
answer no to them and get them into the underwriting department for pre-screening, that'll at least give you an idea whether or not it's best for you to move into a supplement plan at that time. It's about qualifying without interrupting what you currently have in place. And if
Yeah.
what you
Okay.
have right now is currently working for you and you're happy with it, there's the other mode that says if it ain't broke, don't fix it. You know what I mean? That's the other
Right.
part of this deal.
Isn't it,
So
also, isn't all of this based on, and this is interesting because here in the Bay Area, we have a lot of counties. Isn't it some things that are available in San Francisco County aren't available in Contra Costa or San Mateo County? It's done by your zip code, correct?
absolutely. And listen, I've been doing this over 30 years and I used to write a lot of Advantage plans. A lot. And when four of the companies moved out of the zip code areas 3 times in a row, and I had 250 clients on one particular program, I decided at that point it was not in my client's best interest to continue on the Advantage arena. And I
Mm.
specialize in the gap because we don't have those problems. So you're absolutely right, Stephanie. It's about zip codes, and you can have side by side cities. And if
Mhm.
that plan is not contracted in that zip code area, you can't see doctors in there to get paid for.
So
So,
that
Wow.
I just think that is a little known, and especially
correct.
here for people that maybe rent and are going to move from, San
Mhm.
Francisco rent is kind of high now, so maybe they're thinking of going to Contra Costa County or something. I mean, I'm sure people aren't thinking of that.
Yeah, I don't think people think that Medicare as deeply personal as it is, which is why the planning aspect is so
Huge.
key. And sorry to say we are almost at time here. I know we didn't quite get through all of it. I think it's fair to say that both Stephanie and Ted would be happy to be resources. I'll
Yes.
share that information with folks after the fact. But I want to, there's a question in the chat that we hear a lot in addition to Social Security benefits. Well, how do we know it's going to still be a program in 15, 20, 25 years, right? What if we run out of money? So what we generally say, Matt, if you want to speak to that, clearly there's history on our side. It is a civic program and, constituent voting in your politicians' programs. It would be very hard to imagine a world in which people are like, oh, that's okay, just take those away. I paid for 70 years, no problem.
Yeah,
But any
it's
broader thoughts on that?
it's the political football that no politicians truly want to address. It is that sensitive. Yes, there's a lot of speculation. People say Social Security might run out in 2036, 2030. There's all kinds of different rhymes and reasons. So when we start coaching on Social Security and when to take versus not when to take, it is dependent upon each individual's personal situation. So starting with, okay, what does the cash flow need? Do you need to file early? Do you not need to file early? Are you in good health? Are you not in good health? Do you have family history? All these things that we kind of try to assess. And we then secondarily worry about what the politicians are going to do, because at the end of the day, the actuarials, the bean counters that are crunching the numbers with how the funding works and how it's driven by revenues, they're going to find different areas to tweak, whether that means they move the full retirement age to a later year, whether they change the dates of the demographics for which we all apply and don't apply, whether they change the cost of living adjustments every year. There's a lot of factors that can go into that, but there is a general fear of what if it runs out? And if we have clients that are in that mindset, we might coach them. All right, go ahead and start taking it early. Take advantage of it. The kind of the theory is each year you wait to take Social Security, you're gaining another 8% in terms of that monthly increase going up. But if you don't need it and you're financially sound, take it early and use it. Use it for what you want. Spend it, reinvest it, give it away to charity. We don't care. So it's very individualized, but we're of the camp that, hey, don't worry too much about the funds running out because we're going to get a lot of warning ahead of time. That's such a monumental, decision that's going to affect 70 million plus Americans. And the power of the vote will come front and center at either midterms or general elections or wherever that might be. So we've got a lot of passion around that, but I don't know if that helps answer that.
Yeah, I just want to thank everyone who is not a Brio client necessarily yet for coming, joining, and helping get edified on this very important and salient topic. And certainly connect with your advisor if you want to talk about this from the planning side and lens. If you don't have an advisor, call us. And I would love to just again thank Ted for your time and attention, and Stephanie as well for joining us. Matt, thank you so much. And for those who have popped questions in the chat, I'll be following up with you all directly and connecting you with the appropriate party because it is a very deeply personal, set of circumstances to make the informed recommendation for you. So.
Thank you.
Thank you, thank you, thank you. And
everyone.
Suzanne, we're all going to come visit you in Morocco. So hope you have a spare
Yeah,
bedroom.
it's beautiful here.
Love it. Have a good weekend,
But I
everyone.
definitely want to speak to somebody about
Yeah.
it because I feel like you
Yeah,
could.
we'll get
Okay,
you
great.
sorted.
Thanks.
Okay. All
Okay,
right.
cool.
Thanks,
All
everyone.
right.
Do
Bye.
we have Ted's contact information?
I'll
somewhere?
distribute to everybody after the fact.
Thanks.
Yes.
Great.
Thank you.
Everyone.
Bye-bye.
Thank you.
Bye.
Bye.